sign up for our newsletter, because we will be sending out a newsletter that contains both the video and also the link to the case module, so you can re-access those and have them all put together in one email. So maybe that's easier. Yeah, and now it's your choice how you want to do this. Just listen or listen and work on the cases at the same time. And yeah, back to Kai, and we can get started with the first lecture, right?
Yes, and it's my pleasure to introduce Katharina Ziegeler. Katharina Ziegeler is a scientist and radiologist from Berlin, and she has worked extensively in the field of arthritis, in the field of peripheral arthritis, crystal disease, and also in the field of spondyloarthritis, and has recently gained experience in the field of gender-specific imaging, which is a interesting field. It helps us understand diseases better, and the differences between men and women. So we are very happy that Katharina is here today, bringing us new insights on the sacroiliac joint and the differences of the genders.
Hi, thank you very much, Kai, for the kind introduction. I'm really thrilled to speak about this topic. So what I'm focusing on today is the shape variance of the sacroiliac joints, and whether they do in fact play any kind of role in axial spondyloarthritis. Before we dive into what are shape variants and what kind of role they play, I would like to take you on a little detour on sacroiliac joint biomechanics, because this is a really central topic in the area of sort of anatomy of the sacroiliac joint. So just to remind you, the sacroiliac joints are actually one of the main mechanical axes of the human body. They basically transfer the force from the lower extremities, the legs, to the lumbar spine, and they have a very limited range of motion themselves. They can sort of do a little nutation movement, but anatomically they have this very limited range of motion, because the sacrum is basically a wedge in the dorsal part of the pelvic girdle. The joint itself is quite uneven, so there's friction to keep the sacrum nice in place, and also a very strong capsule and sort of ligamentous apparatus stabilizing the joint. So if it doesn't move, what does this joint even do? It actually helps to disperse axial loads. And axial loads are the forces that sort of work on the human body when standing upright, when walking, or jumping. So anything in this kind of vertical axis is called an axial load. So what the sacroiliac joint does is basically it homogenizes this load when it transfers it from the legs to the spine. The loads are not sort of distributed completely evenly across the joint. There's something that we sometimes refer to as a load zone. This is marked red in this image. We have a male sacroiliac joint on the top. A and B and C and D are female sacroiliac joint. You can see there are some gender differences. The male joint is a little larger, and so the red parts are what we would call the load zone. So the part of the joint that most of the forces run over. This is a computer simulation that is based on an actual scan of a real person. It's a female. She has sort of on imaging a completely symmetric joint. And the loads that we are simulating on this model are also fairly symmetric, but you can see here in this area where it's red, those are the load maximum. I think it's a fairly self-explanatory video, but you can see it's not a very symmetrical distribution of force. And this is something that we also see on imaging. So degeneration or any kind of mechanical alterations of the sacroiliac joints are often not very symmetrical in nature. Now, what are shape variants as the topic of this talk? I would like to quickly talk you through these shape variants that we see here, and then also say a few words on classifications, basically. So an anatomically typical sacroiliac joint in an axial slice, these are all strictly axial slices of SI joints. An anatomically typical joint has sort of a convex surface of the ilium opposite a more concave surface of the sacrum. So this is the typical joint. This here is a shape variant. We are fairly dorsally in the joint. And this up here is the joint proper. This is actually not the joint. This is ligamentous portion. There's sort of strong ligaments connecting ilium and sacrum here, but no cartilage. So this is not an actual joint. Sorry. But back here, we see another little joint facet. And this is what we would call an accessory sacroiliac joint. So this is our first shape variant. The second one, you can see there's nudges and grooves. It's fairly uneven. This is what we may refer to as an intra-articular variant, and this may also be called an iliosacral complex. This is a very common shape variant in females. We see it almost exclusively in females, and this is a bipartite ilium. You can see here, this is it's a bipartite bone. This one here is called a crescent-shaped ilium. Please note, actually the relationship of concavity between ilium and sacrum is reversed in this joint shape. So we have a concave ilium opposite a convex sacrum. And lastly, we sometimes see these little ossification centers of the sacrum. This may also be considered a shape variant. What I would like you to keep in mind is that this kind of definition of joint shape variation or anatomical variation is actually fairly visual. This was defined in the late 90s by radiologists, just on sort of how do these joints look on imaging. So these are not derived from pathology or from biomechanics. These are just visual classifications. And please bear that in mind if you ever start reading up on joint shape variants, because they may actually be defined quite differently by different working groups. So what do we know about shape variants so far? Firstly, we know that they are very common in people that have a degenerative or mechanical disease of the sacroiliac joint. In a study from our group, we found that almost all of the women and more than half of the men with clinically diagnosed mechanical joint disease, so osteoarthritis or osteitis condensans of the sacroiliac joint, actually had atypical joints. Furthermore, men with spondyloarthritis have more than double the prevalence of atypical joints compared to the general population. And from this, we derive the hypothesis that atypical joints must have changes in mechanical load, because that is basically what the data suggests. So what we did was we tried to model these joints, much like the computer simulation I showed you before. So basically get a mechanically feasible 3D representation of the joints and expose them to stresses and see what happens. And this is still unpublished data, but we were able to show that, especially in the joints that we would classify as intra-articular variants and crescent-shaped ilium, we find a much higher proportion of joint surface that is exposed to above average stresses. So it may be understood as basically a change or enlargement of the load zone. So what imaging findings do we have to look for? I'm a radiologist, so I want to talk to you about imaging findings. And before we get into that, I would just like to do a very quick recap of what would we consider inflammatory imaging lesions and what would be more degenerative imaging lesions. So in sacroiliitis, the disease starts with enthesitis at the insertion of the cartilage and adjacent bone marrow edema. This is early sacroiliitis in, for example, axial spondyloarthritis. In the areas of acute inflammation, those can regress to fat metaplasia. And in these areas, we will also find erosions as the disease progresses. Going along with the disease, we will very often find sclerosis around those eroded parts of the joint. So this may possibly be understood as a sort of attempt at repair or sort of stabilization of those damaged joint parts. Even further along, we will see new bone formation. So these erosions may fill up. We may see sort of bony matrix within the joint space. And as a sort of last bit of the disease, if it comes to that, we may see complete ankylosis of the joint. The processes at the joint in joint degeneration are quite different from that. It usually starts at the sacroiliac joint, as in any other joint, with cartilage degeneration. And because the degenerated cartilage is not able anymore to give this buffer to sort of homogenize the distribution of mechanical load, we will often see bone marrow edema. And this bone marrow edema should probably best not be interpreted as inflammation, but rather like a bone bruise, even like microfractures. Yeah? So we have mechanically stressed bone that will show up as bone marrow edema. In these areas, we will also find sclerosis that is very common, and in later stages also maybe osteophytes. So which changes are which? We have a number of imaging lesions that we can say those are fairly specific for inflammation. And those are mainly the structural lesions, so erosion, new bone formation, ankylosis. Those are very specific lesions for an inflammatory disease of the sacroiliac joint. Then there are lesions that are more sort of degenerative in nature, or should be interpreted as degenerative. And the main one here is osteophytes. So osteophytes is a classical degenerative lesion. But then there are two kinds of lesions that we see in both, and those are bone marrow edema and sclerosis. So those two kinds of lesions we can see both in inflammation and degeneration, and they are important both in inflammation and degeneration. So we really have to look out for those. I want to look a bit further at shape variants and imaging lesions. So firstly, we found that patients with atypical joints have more sclerosis. So at their sacroiliac joints, even if they don't have any SI joint disease, they have significantly more sclerosis than the general than sort of other individuals from the general population with anatomically typical joints. In patients with axial spondyloarthritis, we found that those with atypical joints actually have a higher likelihood of exhibiting both erosion and bone marrow edema. And the theory behind this, or what we feel is actually supported by what we found, is that these mechanical stresses that I showed you in these atypical joints actually induces inflammation or continues to the upkeep of inflammation. So what do we conclude from this? Firstly, we can conclude that sort of anatomical variation, shape variants of the sacroiliac joints, they do change the load conditions in the sacroiliac joint. We can at least assume that these shape variants predispose for mechanical joint disease to some degree. And we believe that they worsen the imaging appearance of AxSpA. Whether they actually worsen the clinical course of AxSpA is actually very much up for debate, or not yet scientifically proven. Maybe or may not be. We're still looking into that. So as a bottom line, I would say anatomical variation of the sacroiliac joint is both a contributor to and a mimic of sacroiliitis. And if you only take one thing with you from what I talked about for the last 15 minutes, if you interpret sacroiliac joint scans, just take a second and look at the shape of the joint. And if you see bone marrow edema, if you see sclerosis, do look, is there maybe a nudge? Is there maybe another explanation for any kind of imaging lesions? And with that, I conclude the lecture part. And
thank you, Katharina. Yes, so people, you can now scan the codes, and you have, for instance, if you watch on a PC, you can scan the code with your phone, so you can access the case on your phone. And if you have just one device, so if you are out there and watching on the phone, then Eva will copy the link again to start the system, and Katharina will share her screen and will demonstrate the case she has prepared. And I know there are also two interesting questions embedded.
Okay. So I think I've given you enough time to scan the QR code. So I will now stop sharing my PowerPoint and start sharing the case viewer.
You
So
refresh, please. Refresh, Command R to have everything refreshed. Exactly.
Great. Okay, so I would like you to access this case right here. You can maybe deduce that we're not looking at this one quite yet. We were at the sacroiliac joint, so please follow the thumbnail to this case by clicking it. Yeah. Okay. So Kai, what do you think? I would maybe give another minute or two, or should I just keep
Yeah. You explain the case. So maybe you scroll through the case, explain, and then you open the question so people know where to focus on. So everything is set up. Yeah.
Okay. So I have two MR images for you here. I just have to see that I can use the split screen with the full. Hang on, because I'm sharing the screen. So you can, as I showed you here, maybe some of you are already familiar with the use of the case viewer web app or even on a device. So I would encourage you to open up these two sequences. We have a T1 weighted image here on the left side in this case, and a stir or term sequence, at least the fluid sensitive fat saturated sequence here on the right. And then you can basically just sort of go through the scan and take a look at this joint. I just have to link them again. Yeah, now they're moving together. Okay. So you can also maybe adjust the.
Yeah, maybe you show the question for the sake of time so people can vote already.
You're right. I have to. Okay, so there's a question. So which lesions do you see? What do you think you see? Okay, so I will just you can do them on your own time. You probably many of you have already answered.
We have five answers. Five answers are
okay.
there. So we wait a bit. We have more people in the call, so we wait a little bit more. So you can try it. So maybe some of you have managed to access the cases. Now it's 7 answers. If not, that's no problem. We will send you the link after the event on the weekend, and we will explain exactly how to access the cases so you do not miss anything. Okay, now it's 10 answers. I think I share my screen now, so you, because I see that you don't have the expert option, Katharina. That's okay. I will share my. I share it for a brief moment, so you see actually what we have.
I just stop sharing mine.
Yeah. So you see the results here. These are the results. How do you like them?
I love them.
Okay, cool.
Good. So most of you got that perfectly right. So we do in fact believe to see erosion. We definitely see a very uneven joint surface. There is definite sclerosis. And also, of course, signal intensity on the fluid sensitive sequences. Wait, I'll just share.
So you share your screen again, and maybe you focus on the CT. It shows just the CT. You have to answer yourself.
I have to answer myself, yes. And there we go. Got that right. Okay, so 6 months onwards, the patient is still in pain. We did another scan, and just sort of for the sake of time, I'll just sort of do this a little bit more quickly. We still see we still see something that we would have to call bone marrow edema here. Yeah, so there still seems to be some kind of fluidity or disease activity in this joint, even after 6 months of really adequate or sort of usually very effective anti-inflammatory therapy. So I would now like to share the CT image, which is very enlightening in this case. So I'll just hang on. Yeah, I'll just leave it like this. So
we got a question actually in our Q&A section already.
Awesome.
How can you recognize sclerosis on MRI? Was the question.
Very good question. Very good question. So if we want, so sclerosis is basically bone without any fat marrow left. So this is almost entirely calcified. So this is really hyperdense on CT. And that means it doesn't really have any signal on MRI. So if we find something that is in fact low signal on any MRI sequence, then we can say this must be sclerosis. So this, for example, would be an area of sclerosis. You see this bit here and right here. So there's sort of no signal. That is sclerosis. It has the same kind of signal as cortical bone does. So look out for that. That would be sclerosis. Okay, just have to get the CT back. Okay, so now we look at the CT. And now, if we remember back to what were the specific lesions for inflammation, then erosion was one of them. And we actually graded this MRI as positive for erosion. I did that with you. I agreed with you that those were erosions. And now we actually have to look at it, because if it's erosion and it's an inflammatory disease, then we would expect the anti-inflammatory drugs to do something, and they didn't. So that is why we did this CT, to just get a better image of the joint. And I'm going to go through this slowly. We don't actually see any erosions. There are some slight sort of surface irregularities of the joints, but usually you would expect deep erosions, at least this size. So they should be really well visible if there were any, but there actually aren't. There are some subchondral cysts. Those aren't very common in the sacroiliac joints, but they are clearly degenerative in nature. There's vacuum phenomenon, which we would also call a degenerative lesions, and a lot of sclerosis. There's osteophytes back here. It's actually a typical location for a female. This is a female patient, and this is right where we would expect osteophytes to appear in a female. Okay, so basically we don't have erosions. We have a lot of sclerosis, and we have bone marrow edema, and those are lesions that can both be found in inflammatory and degenerative disease. And now I will give you not this sort of paracoronal slice, which is the kind of image that we usually use to look at sacroiliac joints, but the axial slice. And what we have here is a shape variant. So this is a crescent-shaped ilium. The ilium is concave. It should be convex. It should have this kind of shape. It doesn't. And in this patient, we would assume that this is actually what probably at least contributed to this kind of imaging appearance. And so we would assume that this is a very active and, in this case, painful form of sort of osteoarthritis of the sacroiliac joints. And with that, I conclude my case. Are there any questions?
Anything coming in? So thank you, Katharina.
This one. So we can...
Yeah. So the final question on the diagnosis, by the way, is 100% is shape variant. So they all have it right. Yes.
Was a bit of a giveaway, maybe.
Yeah.
Didn't really bury the hatchet there.
Okay, that's very nice. So thank you for your contribution, Katharina. It was very interesting, and I think it will enlighten many of the participants to watch out for more of these lesions. Thank you very much.
Thanks.
So it's my pleasure to introduce our next speaker, which is Denis Poddubnyy. He's a rheumatologist, and he's also leading the rheumatology department at Campus Benjamin Franklin at the Charité University Medicine in Berlin. And he has extensive knowledge in spondyloarthritis and in all the rheumatoid diseases affecting the exoskeleton, of course, all the peripheral joints like psoriasis. And he's today speaking to us in his role as co-founder of a group for artificial intelligence diagnosis of certain diseases in the field of rheumatology. And Denis, I'm very curious to hear your experiences in this field. Thank you.
Thank you very much, Kai, for inviting me. I'm really delighted to be here and to talk about a really very current and evolving topic. And I will try also to bring an example of a use case in rheumatology for artificial intelligence. Give me just a second to share my screen. Now you should be able to see my screen. And here you see my disclosures, which are, however, not really relevant for the content of this talk. And I would like to start with just a definition of what artificial intelligence is, because you hear many terms: artificial intelligence, machine learning, deep learning. So the artificial intelligence is an overarching term that involves even earlier experiments with algorithms mimicking what human beings are normally doing, like playing chess or other games. Then around 1980, approaches of machine learning came in, and you all know machine learning approaches also in biomedical research. For example, a clustering performed by a statistical program is a sort of machine learning approach. The real breakthrough came in after 2010 with the development of deep learning, which is based on training of artificial neural networks, in fact working very similar to the neural networks in our brain, in particular that includes also computer vision. So I will try to address two major questions. The first question is, when we talk about rheumatology as a clinical discipline, is whether artificial intelligence can make the diagnosis of axial spondyloarthritis or ankylosing spondylitis or any another disease. So, and I need to say clearly, we're not that far yet, and probably we at least in the nearest future, we won't be getting there. There are many reasons for that, and the main thing is that we have a conversation with our patients. We receive a lot of information. We need to interpret this information in an appropriate way. It might be that language models will be trained in the nearest future, but it's not yet the case. However, it could be, and you all aware of the large language models. Probably you all already tried one of them. One of the most popular ones is ChatGPT, developed by OpenAI. This is not the first, and maybe it's even not the best, but they have the best marketing strategy, and they trained the language model very well. So what this language model is doing, this is in fact an artificial neural network and the algorithm which is trained on billions and billions of texts, books, articles from journals, everything what was available for the algorithm until December 2021. And the developers of ChatGPT, they provide a very clear overview of capabilities, but also of limitations. And this is something we need to take into account, that occasionally also incorrect information can be generated. And as of today, as I mentioned already, there is a limited knowledge of data which came out after 2021. Nonetheless, on standardized questions, the algorithm can provide substantial amount of knowledge, demonstrate this knowledge. That was an attempt to test the ChatGPT on US American medical exam, and as you can see, the algorithm was very close, or even past reached the pass level on multiple choice answers. However, if you ask any large language model about a specific disease, for example, I did this exercise, I asked my patient with back pain have axial spondyloarthritis, and the question is nearly always, as an AI language model, I cannot diagnose the patient condition. And this is very true, but this language model is able to provide you with particular information which was available for this network during the training process. So the answer to this question is no. Artificial intelligence currently is unable to diagnose any disease, including axial spondyloarthritis. So we still need human intelligence here for the interpretation of information given by the patient, and of course, clinical examination. Then there is an attempt to use big data to apply artificial intelligence for big data to identify patients with high probability of axial spondyloarthritis or other diseases. So these big data are coming from insurance claims data, for example, or electronic healthcare records, and there are some proof of concept studies which were quite beneficial, demonstrated some positive effects. So potentially yes. However, we have substantial differences in healthcare systems around the world, which would make the generalization of those models rather difficult. And finally, the question would be whether artificial intelligence is able to help with imaging and its interpretation. And in the area of axial spondyloarthritis, we have two major types of imaging. You also heard about X-ray, of MRI, and CT, but X-ray and MRI, these are most commonly used tools when we try to make the diagnosis and differential diagnosis of axial spondyloarthritis. And it is indeed possible that we train the artificial neural network to recognize particular features. Of course, for this, you need really big base of images and appropriate labels. Labels should be very reliable in order to train the network. And how is it working? Normally, we're giving to the artificial neural network images and labels. This is so-called training data set. And the algorithm is trying to extract imaging features which were relevant to generate the particular label. For example, in case of X-rays of sacroiliac joints, we would be training on the labels. Definite radiographic sacroiliitis is present or absent. If we talk about MRI of sacroiliac joints, the story is getting more complex because we need to recognize a variety of changes in the context of changes seen on another sequence, active inflammatory and structural lesions. But this is potentially possible, and this has been demonstrated in several works. Here we provided the proof that it is possible to recognize definite radiographic sacroiliitis in a standardized way, and here we looked at the performance of the algorithm in the diagnostic setting. So for the development of this algorithm, for the training of the algorithm, we used indeed a very big database of well-standardized images which were assessed in a way involving central readers, and we validated this data in another separate data set as evaluated by other central readers. So here you see the performance of the algorithm. Although you know that X-ray of sacroiliac joints is not very reliable method with huge inter-reader variability, we could achieve an accuracy on the detection of definite radiographic sacroiliitis of about 90% in the validation set and about 88% in the independent test set. And this is something you can try already now. The algorithm is available under this link, and we will try to do this together with you in a second. So now it's time to switch to Berlin case viewer. Probably you are already on the right page with a case viewer. So I will just switch to this case I prepared for you for today's lecture, and this is a case of 45 years old female patient who came to us with low back pain for approximately 15 years. With morning stiffness lasting quite long, improving with exercise. Sometimes she experienced night pain and buttock pain. There were no other spondyloarthritis manifestations, but spondyloarthritis family history. B27 was positive, CRP was normal, no physically demanding job or hobbies, and she reported a history of 2 pregnancies and delivery. So I think this case fits very well to today's topic and what Katharina already presented. So here you see inflammatory back pain that started before 45 years of age on the background of family history of B27 positivity. Not surprising that primary care physicians raised the question whether it could be axial spondyloarthritis, and we performed X-ray of sacroiliac joints. First, you see that this is a pelvic X-ray, and the question to you would be if you think that definite radiographic sacroiliitis according to the modified New York criteria is present in this case or not. So please try to answer this question. So if you remember, definite radiographic sacroiliitis means grade 2 or higher bilaterally, or grade 3 and higher unilaterally. So whether you think that this would be something compatible with definite radiographic sacroiliitis. So we can have a look at the result. Oh, this is a very nice result. This is really great, because here we have really 50-50 share. So some of you said yes, this is definitely radiographic sacroiliitis, and I heard this opinion from experienced rheumatologists, because if you look formally to this joint, you see that the joint space is somehow blurred and cannot be followed. So formally, you can talk here about partial ankylosis, but to be honest, this structural lesion and this structural lesion, they look strange. They do not look very well compatible with axial spondyloarthritis. But in any case, we can ask artificial intelligence what would be the opinion based on the training on those 2000 images it saw in the past. So you can upload, you can even generate activation maps. So in this case, to get the quicker result, I would refrain from this. And here you see that artificial intelligence thinks that definite radiographic sacroiliitis is absent, and you even receive a numeric value for this. So here we took a balance cutoff with balance sensitivity and specificity. And if you generate gradient activation maps, you can even see what was the region which affected the decision on presence or absence of definite radiographic sacroiliitis. But this is certainly the case where you can think about different possibilities, and that is why in this case we need cross-sectional imaging. And we see here several sequences. I would go, in the interest of time, just into 3 sequences very quickly. The first one is STIR or T2 with fat suppression, where if you go into the ventral part of the joint, you start seeing bone marrow edema. You see bone marrow edema, which is quite prominent in this case. If you go to T1, and again, in the mid part of the joint, there is nothing here, but if you go to the ventral part of the joint, you see suddenly a lot of dark signal, and that was also dark here. So this should be sclerosis. Sclerosis we saw here on X-rays. And then the most important question here would be whether or not there are erosive changes. For that, you can apply an erosion-sensitive sequence like WIPE sequence, and then you see that there are no erosions there, no ankylosis. If you don't have it and still in doubt, you can use also CT or low-dose CT. And in this case, also you see that there was a capsular acidification indicating mechanical overload of sacroiliac joints. So this is a classical picture of osteitis condensans ilii with persistent mechanical stress, where you have bone marrow edema, where you have sclerosis, but you do not have typical structural damage typical for axial spondyloarthritis. So I switch now back to my last part of the lecture. So the question would be, X-ray is good, but what about MRI? Yes, we're working on this, but we're not as far as with X-rays with that. And the problem is really a complexity, difficulties with standardization of sequences and of projections. And we also interpret always changes in the context of each other. So here, this is a work which provided a proof of concept that artificial intelligence approach can be used for standardized evaluation also of MRI. In this case, we had more than 500 patients scanned on different scanners with inconsistent protocols. That was important for generalization of the results of the algorithm. We provided labels on active inflammatory changes, on active inflammatory lesions compatible with others definition, and on structural lesions. The algorithm received both types of images at the same time, and here you see the results. If you look at the active inflammatory changes, you see that the performance of active inflammatory lesions recognition was very close to the performance of the experts, while structural changes were still better recognized by human readers. And also here we had a chance to visualize the prediction. Here you see very nicely that the algorithm started to learn where are the sacroiliac joints and where are the pathological lesions. So if we ask the question whether artificial intelligence can help with imaging and its interpretation, the answer would be yes. I do think that standardized evaluation of imaging is possible, and it's expected to become available in the nearest future, at least in clinical trials. This should be easily possible, but we also aim to introduce those assistant tools in daily clinical practice. Thank you very much for your attention.
Wonderful, wonderful talk. And it's really nice to see this algorithm in action, and it's even nicer that you are providing the algorithm for everybody to test yourself. So when you, after the seminar, if you have a challenging X-ray of the pelvis and you want to try it yourself, then you are happy to use it. Maybe Dennis, after the discussion, you can post the link again in the chat so people can grab it and save it for further use. That would be nice. So Eva, do we have any questions regarding Denis' talk?
Not yet. I'm still. Oh, there's the first one. Could osteitis condensans ili be unilateral or asymmetrical? Yeah, we talked about osteitis condensans ili just last week, and there will be a blog post coming up on a Berlin Case Viewer blog, just to mention that beforehand. But there it's about osteitis condensans ili versus axial spondyloarthritis. But this question,
yes,
maybe you
yes.
want to answer that one.
Yeah, we learned a lot about osteitis condensans ili in the last couple of years. It could be indeed asymmetrical. It depends on whether you have more loosening of the ligaments supporting the joint. So it could be on both sides, but could be also unilateral. And in the past, when we applied only X-rays, we saw changes almost exclusively in the ileum. That is why the term osteitis condensans ilii. But if you look at MRIs, if you look at CT, you see changes occurring at both ileum and sacrums. So it is possible to see those sclerotic changes in both parts. Important again, the localization, mechanically induced bone marrow edema and sclerosis are localized in the very anterior portion of the joint, not in the mid part of the joint. And they are normally not accompanied by erosions or backfill. And of course, no ankylosis is expected in mechanically induced condition. So I will also post the link, and I think Marlena, since we lost our moderators, I would just pass over to you. Yeah, it's your turn.
You were amazing. Thank you. I've learned so much, and what I'm happy to hear is that I'm still going to have a job. I saw one slide that you said that you still need me, so I'm very happy that that radiologist audience is still going to be necessary for deep AI. And I'm looking forward to amazing developments because it's very complicated. I love to be amongst both of these previous speakers because of biomechanics. I'm a foot and ankle radiologist because I love biomechanics. And as we understand, either through the shape changes or through just different deep AI learning, we're going to understand and take in all these complicated factors at the same time. And that's why, I like the foot and ankle because it's complicated. Shall I just take over, Kai?
Yes, Marlena, it's wonderful. I think it's really cool that you now have taken over, and I'm happy to see your presentation. Thank you.
Excellent. Let's just get the slideshow. Get slideshow from the beginning. Excellent. So great to meet you all. I'm Marlena Jbara. I'm a board certified radiologist. I have no financial relationships to disclose. I'm going to take you through some guidelines of imaging of the diabetic foot, and we'll take a look together about the pathophysiology because I think it always starts with some good science, and we'll take a look at some findings. I'm really grateful to be here with Berlin Case Viewer, and I think that what they have done to make images available to everyone is going to really be a breakthrough, considering what's changing in the markets of radiology. But let's talk about the market of radiology. Let's follow the diseases. Diabetes is common. It's the 7th leading cause of death. I was able to pull up the most recent statistics this week that were just taken from 2022. So I've loaded those up. And there are now 537 million people that have diabetes worldwide. That's 1 in 10 people. So if you're in a room of 10 people, 1 of them has diabetes, and it's killing someone 1 every 5 seconds. They say an amputation occurs somewhere every 30 seconds. That was the old thing I thought was triggering. This is even more triggering. And if you're a diabetic, you're a sick patient to us. So you have nephropathy and renal failure and all sorts of problems. And if you had COVID, you were more likely, if you had diabetes, to pass on, unfortunately. When we talk about the numbers worldwide, I left the previous slide because on the current, this was what I used to lecture from. And if you look at 2015, we said there'd be 415 million, and in 2040, there'd be 642. Well, we're fast tracking it just like we do in America, right? And everywhere in the world. And it's now 643 million will be 2030. So you see, we're already 10 years ahead of ourselves. And those numbers you can check out on IDF Diabetic Atlas. They have great statistics. The global burden, I mean, it's all over the world globally. I mean, down to even the French Polynesia, where more than a quarter of the population have diabetes. And who gets it? It's not just everyone. It's in America, if you're a person of color, if you're an American Indian or a Hispanic non-white heritage, definitely you're going to be at higher risk for diabetes. And it's an interesting disease. I think everyone should get interested in it because it's where the money is spent on every level. So everyone's interested in this, not just the patient or the doctor, but the corporate sectors, and AI is interested in this as well. It's expensive. Look at what it's costing America, $966 billion in 2021, huge. And it's up 316% increase in 15 years. I talk about this because this really centered my why and why I'm a radiologist and what I'm doing to help people. So I think it's important to understand the numbers that we're getting in with, and that the global cost, it's not just in America, is going to cost us over $1 trillion by 2030. And I'd like to spend that on the education of my children and our children's children, and rather than chasing diseases. So we're going to do something about it. What are we doing about it? Amputations have been on the rise, but the amputation types are changing. And it's very interesting. If you follow the bucket of money, you'll understand what's changing. So if you look at these graphs on the top, I'm looking at people with diabetes and people who don't have diabetes. That's your smokers and peripheral vascular disease. That's kind of getting lower as that goes out of vogue. But the diabetic amputation types are changing. While they're all going up, the smaller amputation types are increasing, and the transmetatarsal and BKAs, the below knees, are going down, thank goodness, because those are associated with a higher rate of mortality. And when we look at what's really going on and get honest about it, Medicare in America, we cover all of our elderly. We looked at 1 million patients who get serviced by Medicare, and we found that if you are African American, you were more likely to be offered an amputation. If you were white, you were more likely to be offered a peripheral vascular intervention. That would give you more time on that limb by repiping that limb and getting more blood, and you would live longer with your limb. So essentially, if you get an amputation, you're more likely to get more amputations, and that carries higher mortality. So in effect, there's mortality issues wrapped up in these numbers. And what can make a difference? Take a look at the ulcer that someone has and pay attention to people, and that might be the source of getting people well. So if we diagnose things early and prevent it, obviously people will do better. That brings me to my own private plug. While I was sitting in my reading rooms in my early part of my career, I used to say, these doctors, what are they doing? They're just amputating. And I studied some of these amputations, and I wanted to see if doing an MRI would make a difference. And I found independent correlating variables and all sorts of coefficients in science that it didn't make a difference. If you got an MRI, you might still get another amputation. But if you got an MRI, it decreased the death rate. And that was interesting to me and spurred on the rest of my career, which is looking to see how I can, make an impact in a disease that's really hurting so many of us. So the diabetic foot, getting to what you came for. I know I probably don't have much time left, but the diabetic foot is a mixture of diseases. This is peripheral vascular disease mixed with neuropathic problems leading to an ulcer, getting you osteomyelitis, and then a limb amputation. And here's some pictures of what some of those multiple amputations might look like in your forefoot. And it looks like this when you're walking or not feeling that you're pressurizing parts of your foot, and until your skin breaks down and direct spread of infection leading to osteomyelitis. And that's how it goes. We need an ulcer to break the skin, and then there's a direct spread of infection. That's this type of infection. So start with a callus. Everyone who's got calluses and you're running, think about 20 years down the line. If you're a diabetic, you might want to offload your calluses. So having excellent foot health is going to be important. These are just some examples of what that looks like. So the science of this is very interesting to me, and you can see it on the x-rays. So diabetic neuropathy is basically 3 pillars. You've got sensory, motor, and autonomic neural problems. I'm very interested in the motor section, where having so much sugar around sits on the nerve, causes the nerve to go into tetany, and you start to make your muscles atrophy. So you're firing on them so much, they atrophy. And what happens is the foot becomes unbalanced and you begin to wobble. And that will cause you to claw your toes and create a whole bunch of biomechanical changes, just like our previous speakers talked about in the sacroiliac joints. All that matters. Like how you load a joint is going to matter how you break the skin, how much pressure is applied. Of course, pain, temperature, vibration, touch is off. That's all affected by demyelinization, causing you to forget that you have your foot on the heater and it burns, and there you have an ulcer. And of course, without you realizing it through the years, autonomically, you're shunting your blood away from these areas. You're not able to heal. You're not able to remove the diseased tissue. What do we want to do about it? Lots of people are in the business of telling us. So Infectious Disease Society of North America, 2023 guidelines, haven't changed all that much. If you have a suspected diabetic foot infection, they want to know what the organism is before you treat it. We have so much antibiotic resistance right now, we have a problem. So how are you going to figure that out? You don't want to just swab it. That gets a whole bunch of colonizers. You want to get to the base of it. So you curettage it. And they give you all these guidelines. They're available to you. You can review this after the presentation. And it's all over the world. I've looked at all the guidelines. They're all about the same. They want you to get an X-ray first in imaging. And then if they can't tell from that, we're going to move you to an MRI. Some people talk about CAT scans. I'm a big fan of MRI. And we could talk more about that. Moving on, what is the problem with Charcot? So Charcot basically is this severe progressive arthropathy that occurs where trauma is occurring and you're not having time to heal it up. So you have this repetitive trauma on an insensate foot and your bones begin to crack along each other and you get these Ds, we call in America, dislocations and debris. And you can see on this X-ray that fluffy new bone formation as the bone is fragmenting and fracturing as you're creating these malalignments in your forefoot, you change your weight-bearing pressure. And of course, it's the same science that I just spoke about, why that's occurring there. And where it's occurring mostly, about 85% of that is going to be between your mid and forefoot. So that's the place when you're looking at X-rays, start looking at those, toes and all that, all of the different biomechanical changes you can see. For Charcot, here's an example of, and we can see many more on Berlin case viewer. By the way, I'll be, looking at those as well. For dislocation, here we have a talonavicular dislocation. You can see the talus is fragmented, the navicula is in pieces, medially subluxing off of the navicula in this person who the day before seemed fine, and then today this happened. So these are more chronic forms of Charcot where you see multiple fractures, metatarsus adductus, attempts at repair with callus formation. You can see the bone bridging and osteophyte formation, very irregular when you're looking at this, and the change in the shape of the foot. We have a rocker bottom deformity, and pay attention to the skin. It's always about your soft tissue. So you want to get your technologist to really be able to bring out all the science there is on the X-ray. When I look at X-rays, I always tell my students, I want you to magnify the image and get into it. You want to see the density change here, be able to alert yourself there is an ulcer there. And then you can furthermore look at the break in the cortex. So if you go up the bone and you get to a point where you can't go anymore, that's technically an erosion. So we're looking at different erosions here where you're having your eye go up the cortical bone, erosion occurs very close to the area of the ulcer, high likelihood of osteomyelitis. Don't forget to look at your laterals. You want to assess the soft tissues on the lateral because sometimes your hammer toes in a shoe can be a problem and you get an ulcer there and it may be difficult to see on a frontal X-ray. What's there to see? Again, we're looking at subcortical lucencies in this case, which is indicating that there's a degree of osteopenia and an erosion at this particular location. When I see this across a region this way, I understand that there must be a raging soft tissue infection that might be allowing this infection to travel, say, up the deep transverse intermetatarsal ligament. And here's an MRI correlate to show that. When we're talking about MRI and we're talking about osteomyelitis, it has to be T1 marrow, complete infiltration. And that's what is the best sign that they found surgically proves that there will be osteomyelitis so that we make sure to diagnose this properly. Subacute osteomyelitis, we can use terms like sequestrum, involucrum, and cloaca. These are things where we have a sequestered piece of dead bone in the center. We put an envelope of bone around it. That's your involucrum. And then we put a tract out of that region, out the skin. And that's really letting the pus come out of a pimple, so to speak. And that's when you see those three together, you're in a hat trick that's for sure subacute osteomyelitis. Why do you do X-rays? To see everything else, right? You want to make sure that you can see, in this case, I have some erosion here in a patient who has osteomyelitis. Here's some necrotizing gangrene. I've already had an ulcer and I already have osteomyelitis. But here, well-defined erosion, overhanging edge, large nodular tophaceous gout, osteoarthritis, right? Asymmetric joint space narrowing, osteophyte formation, and calcium hydroxyapatite deposition. Don't forget about the calcium. So they go from the subtle, these X-rays. You want to really blow up and magnify your images so you can see what it looks like to have subcortical lucency as subtle as a distal phalanx like here. And to the complex, you're going to have to compare multiple issues at the same time. You want to have all of your old films. You want to have excellent integrity in the way you read your images and be able to be sure about what you're saying. Here you see an ulcer and the erosion next to the base of what remains of the proximal phalanx. here's a guy, unfortunately, he has calcaneal osteomyelitis and he has no soft tissue, and you're seeing the erosion of the calcaneus. It goes from the acute, where I'm seeing basically erosions and periostitis, to more chronic changes that I'm seeing new bone laid down and more chronic calloused sclerotic bone, much like we're looking for in sacroiliitis and healed sacroiliitis. When we look at these over time, unfortunately, many will recur, even with expensive tissue flaps. We can see here there was a soft tissue flap, but now we can see this erosion and poor definition of the cortex in a patient who has osteomyelitis. Of course, the neuropathic reversal of the soft tissues in this patient who's collapsing at the midfoot. And that got me to Berlin case viewer time. Fantastic. I'm so glad to partner on this lecture with this. So let me just bring it up from I'm looking in the chat, and then.
Thank you, Marlena. So we have now included this case on foot imaging. So if people want to view it, so we did not include the multiple choice questions. Marlena, you can present it as usual. Only you need to share your screen with the viewer, if that is possible. And you guys who only see 2 cases need to refresh the browser. So all the 3 cases are visible.
Yes, I have to share the right link. Let me just do that here.
Yeah, maybe if you just share the browser window.
I'm sorry about this part here. Okay, let's see if I share that. Okay, and then I have my name and my email. Just bear with me. Thank you. You already have an account with these credentials. Join now. I want to join. You know, is it possible for you to take over and share your screen?
But yes, sure, I can do that. Only I would like to be sure that you have this
and with the case, and I will talk it through.
Yeah, we can do it. Okay, so now I'll check my screen, and this is case number 3, left foot pain. Hope you all are able to access it, and it's worthwhile watching Marlena talk to the case, because she knows a lot about foot, as you know.
When we're looking at diabetic foot x-rays, what you want to do is always have an understanding where you think the ulcer would be. So you have to have excellent communication with your clinicians, and that becomes essential. And when I look at this first frontal film, it's difficult for me to say where exactly is the ulcer. I believe I see some soft tissue swelling along the great toe, and this presents the problem with an x-ray. One single view may not give you all that you need. Can you go to the next view? And so now I begin to look into this film, and what I see is along the great toe, along the IP joint, I see some type of bandaging, and that clues me in that there might be actually something there to look at. So I try to tunnel my vision towards that area. And when I begin to see that there might be subcortical lucency at the head of the proximal phalanx, I'm thinking that there's something for me to step up my MRI. And what I do generally in real practice, I tend to do it non-contrast. I want to see if they have osteo, and I only need T1 weighted imaging for that. And because I know that these diabetics have a really terrible renal function, I'm not a big fan of giving contrast unless I absolutely need to. So you can bring up the MRI now. What we're going to do is let's take a look at what we think about this, and let's, okay, yeah, great. So when I first come into this case, what I see is a lot of fusion. Like what I'm looking at on this axial long axis T1 weighted image is lots of marrow that's normal appearing. I see brightness, that's fat, that's very good. And that's not what I'm looking for. I'm looking for the T1 marrow infiltration, which you're seeing as you come into the great toe. And if you move that into the center of the image, the great toe, you can see as it in its flexion deformity, because unfortunately this person probably had spondyloarthritis and developed a mallet toe, as many of them do. But now what has happened is an ulcer has occurred. Did you want to pull the history? Fantastic. So yes, so the patient has had diabetes, but in my opinion, there's more to the story here than just diabetes. There may be some underlying inflammatory arthritis that has caused him to fuse, but irregardless, what we're looking at on the great toe is that he has a mallet deformity, and now he has T1 marrow infiltration. Now we take a look at the T1 where the diagnosis is made. And now let's go to the long axis T2, which is the next sequence, okay? Fantastic. And for many people, when you're approaching imaging, you want to have the conspicuous image. So you want to bring up your T2s first. That helps you to see where things are. And then you can go back to the T1 and see it with more clarity what you're exactly looking for. And now I'd like to take you to the sagittal T1, because you can see, I'm sorry, I'm moving a little too fast here. But now I can see, as I look to the great toe, if yes, please do that. And you can see on the great toe that there's some kind of sublucency along the dorsal aspect. That's not a lucency, it's a hypo-intense region. And that's gas that's trapped in a bandage on the top of that. And then as you go from the skin down, you're seeing infiltration of the soft tissues, which is all this intermediate signal, and then getting into the bone, more hypo-intense. And if you scroll medial to lateral, you're going to see that at the joint, the proximal phalangeal head has been replaced. That's a T1 marrow replacement. And right on that image, you want to prove to yourself that you can actually have length in the bone, because obviously we want to be sure when we're making the diagnosis of osteomyelitis that it's really there, because people are going to get an amputation or may, get extended treatment. So we want to be sure, and I'm sure AI will help us downstream. But for now, what we're doing is looking for T1 marrow infiltration. Let's compare that to the T2, which is the next one. Perfect. Thank you for bringing them up side by side. So much great functionality here. You see it's light bulb bright. Clearly there's inflammatory change at this joint, and it's contiguous with the skin and a soft tissue ulcer in this patient with osteomyelitis and septic arthritis. We can see some of the features of neuropathic joint as well in this case, where you're looking at the reversal of the plantar soft tissues. And if you just scroll out slightly, go from 10 to 11 to 12K, you're going to take a look at the cuboid and how it's creating this pressure effect on the peroneal tendons. This is after we fail on the forefoot, we're going to start to reverse our weight bearing. And of course, cuboid becomes an important part of the disease of osteomyelitis in these patients. So this is a great example of osteomyelitis in a person who has neuropathic osteoarthropathy, perhaps underlying inflammatory arthritis.
Thank you for this fireworks of explanation. So if you want to continue with the PowerPoint, or are you already done with the PowerPoint for today, Marlena?
I can keep going. I always have more, but we can stop anywhere you want.
Okay, thank you. So thank you for the presentation. It was very interesting to learn. And I'm curious to know if there are any questions on the topic, which is also, I think, for us working more in the field of rheumatological imaging, a field that we know very, very few, and it's good to learn from you. So, any questions from the audience? I see one. That's just some praise for us, and thank you, Elena, for this comment, and thank you, Marlena, for presenting. So, are there any other questions coming up from you? Do you want to discuss with us? Do you want to voice chat with us? That's possible. Otherwise, thank you very much for taking part in this seminar on World Arthritis Day. I'm currently in London. It's rather late here today. It's a worldwide attendance, so thank you very much for everybody. We will follow up with ways how to access the recorded live stream, how to access the cases, and we will even enhance the cases in between, so you can get all the details with pixel accuracy. And thank you for joining today. Have a nice day.
Thank you also from me. I don't think there are any more questions.
Are we finished live now?
Yeah, I think we finished.
Great.
I guess I will post the link to our website again in the chat, if you want to sign up for the newsletter, and yeah, so you get all the information. And there's also the YouTube video. Once the live stream is done, the whole event will be uploaded as a video to rewatch at any time. Yeah, so thank you, everybody.
Yes, thank you all. Have a great day. Dennis, you're muted. Okay.
And now I'm muted. I just want to say thank you to Eva, Kai, and to you, Marlena. It was great to meet you.
Likewise.
Yes.
I look forward to more.